Let's discuss on glycogen storage disease. Glycogen storage disease is a group of genetic diseases that results from defect in an enzyme required for either glycogen synthesis or degradation, characterized by deposition of either normal or abnormal kind of glycogen. And there are around 13 type of glycogen storage diseases, but here we'll be discussing few of them. So, versatile player Corey Anderson made history. This is a just mnemonic. We'll pick up the first alphabet of each of these words. Like V stands for von Gehrig's disease. This is due to the deficiency of glucose 6 phosphatase. Second is the P for Pompey's disease. So it's due to the deficiency of acid maltase or acid alpha glucosidase. Third is the Cory's disease, that is due to the deficiency of D branching enzyme, that is also known as limit dextrose or Forbes disease. Then next is Anderson disease. Anderson disease is due to the deficiency of branching enzyme, that is also known as amylopectinosis. And then M for McArdle disease, that is due to the deficiency of muscle phosphorylase. And H for Hirsch disease, that is due to the deficiency of liver phosphorylase. So all these 6 types, most common types of glycogen storage diseases. Then von Gehrig's disease, in nutshell, it's due to the deficiency of glucose 6 phosphatase, and the organ affected are liver and kidney, and that is associated with severe hepatomegaly, hypoglycemia, and acidosis. These are the main features. While Pompey's is due to the deficiency of acid maltase, it is a lysosomal disorder. The enzyme lies in the lysosomes. All organs are affected, and infant mortality due to the cardiac failure. Then Cory's disease is due to the D branching enzyme, deficiency of D branching enzyme. Muscles and liver are mostly affected because these are the basic site for synthesis of glycogen. Then milder form of von Gehrig's disease. All symptoms are more like von Gehrig's disease in the milder form. Then Anderson's disease is due to the deficiency of branching enzyme. Liver and myocardium are worstly affected, and death from liver cirrhosis before the age of 2 years. Then McArdle's disease, it is due to the deficiency of muscle phosphorylase, and it leads to the muscle cramps due to the severe accumulation of abnormal kind of glycogen, which is not able to be converted into the glucose, and painful exertion. And then Hirsch's disease is due to the deficiency of liver phosphorylase, and its symptoms are more like milder form of von Gehrig's disease. So this is in nutshell the view. Then glycogen storage disease type 1, that is the von Gehrig's disease. It is of two types. One is the type 1A and second is the type 1B. So let's discuss upon the von Gehrig's disease. The von Gehrig's disease is most important, most common type of glycogen storage disease that is associated with fasting hypoglycemia, ketoacidosis, lactic acidosis, hyperlipidemia, and hyperuricemia also. So we will see from this flow sheet diagram how these symptoms are manifested in the child, in the infant suffering from glycogen storage disease type 1. So it is the glucose 6 phosphate, and due to the deficiency of this enzyme glucose 6 phosphatase, so it is not able to be converted up into the glucose. So patient will suffer from fasting hypoglycemia. Secondarily, the excess accumulation of this glucose 6 phosphate is diverted to the synthesis of ribose 5 phosphate and NADPH via the HMP shunt or pentose phosphate pathway. Then these NADPH will be utilized further for the synthesis of fatty acid synthesis and cholesterol biosynthesis. So the synthesis of these two fatty substances is increased, leading to hyperlipidemia. Further, the ribose 5 phosphate is also diverted to the synthesis of PP, that is the phosphoribosyl pyrophosphate, which is a precursor for synthesis of purines and pyrimidine. So there will be excessive synthesis of purines and pyrimidine, and purines degradation will also be increased, and that will be in the form of uric acid, and that is the degradation product of purine, and it will keep on accumulating, leading to hyperuricemia. And then further, this glucose 6 phosphate, it leads to excessive glycolysis, and due to the excessive glycolysis, dihydroxoacetone phosphate is being synthesized, and it is diverted to the synthesis of pyruvate. But pyruvate it's not completely utilized in the Krebs cycle, because there are many limiting factors like um, a concentration of oxaloacetate, etc. So it's not completely utilized in the Krebs cycle. Rather, it is diverted to the synthesis of lot of amount of lactates. Lactate accumulation will lead to lactic acidosis, and this is the region under the harsh acidic condition. There will be precipitation of uric acid and accumulation. So that will lead to gout-like symptom, because it competes with, especially in the kidney, competes with uric acid, leading to the precipitation of uric acid and leading to hyperuricemia. Then TCA cycle citrate buildup is also there, because TCA cycle is also increased rate of TCA cycle. So buildup of citrate will divert it for the synthesis of fatty acids and cholesterol via acetyl coenzyme, because citrate in excess amount reaches to the cytoplasm. Here, under the influence of lyase enzyme, it revert back to oxaloacetate and acetyl coenzyme, and which is the precursor for synthesis of fatty acid and cholesterol. So that's how the patient in both the conditions, it is hyperlipidemic, right? Then acetyl coenzyme in excess amount is diverted to the synthesis of ketone bodies. So ketone bodies in the form of acetoacetate, beta hydroxybutyrate, and that leads to metabolic acidosis. So that condition is ketoacidosis. That's why patient will be in a state of hyperventilation. So these are the important features associated with von Gehrig's disease or glycogen storage disease type 1. And these are the clinical features. Onset is 3 to 4 months. Autosomal recessive disorder. The face become doll-like, fatty cheeks, thin extremities, protuberant abdomen is there, short stature, hepatomegaly, and kidneys also enlarged. Intestinal mucosal cells are enlarged, no splenomegaly, and no muscle involvement. Then that was the type 1 and type 1A. Now the type 1B disease. This is the comparative account of type 1 and type 2. So the treatment for type 1A, in which there is a deficiency of glucose 6 phosphatase enzyme. So gene therapy, which is still in a infancy stage. So that can be the only treatment. And then symptomatic treatment can be given, like for hyperuricemia, allopurinol; for hyperlipidemia, hyper dyslipidemic drugs can be given. Then hypoglycemia, to meet with this, uncooked corn starch and frequent infusion of glucose can be given. Then antihypertensive drugs can be given if the patient is having the hypertension. And then type 2 is another variant of this Van Gehrig's disease, type 2 1B, in which there is a defect in T2 transporter in endoplasmic reticulum membrane. So you can see it here. This is glucose 6 phosphate. It enters the endoplasmic lumen, and in the endoplasmic lumen, it can be converted up into no it can be utilized for synthesis of glucose. This phosphatase enzyme is here inside the endoplasmic reticulum, and this is the transporter. So if there is a defect in this transporter, there won't be any transport of this glucose 6 phosphate, and thereby the type 1 disease is manifested. So clinical features are associated with neutropenia, neutrophil dysfunction, platelet impairment, the risk of bleeding, infection, frequent epistaxis is there.